Good evening. I am Dr. Abhay Bhave. I'm a hematologist in Mumbai, and it's a proud privilege and honor to be part of this inaugural function and CME in hematology organized by Bhumi and Sandeep Nemani. I wish them all the best for the Usha Hematology Center and the Nihira Diagnostic Laboratory. Both have had outstanding careers so far, and I'm sure the twin cities of Sangli and Miraz are going to see tremendous benefit out of their presence over there. I'm also very happy to be in very august company of Professor Vikram Matthews and Professor Sukesh Nair, dear friends of mine, and I miss meeting them at the venue over there. The job description for my discussion this evening is on deep vein thrombosis and its management. So there are certain concerns regarding DVT and PE, which combined together are called as VTE, that is venous thromboembolism. And the reason we are discussing this is because there are a few points that we have to bring out. One is awareness to be able to make a diagnosis of VTE. That means what are the symptoms, how to prevent a VTE. This is done through risk stratification and thromboprophylaxis. And how to investigate a VT if it does unfortunately occur. Do you do all investigations or do you do some investigations? So I've called it all or some phenomenon. And if VT does occur, then how do you manage it? And I'm going to share a few thoughts on where your thinking can be different, especially in terms of unusual sites of thrombosis, cancer-associated thrombosis, and APLA-related thrombosis. And I think we should look at this more from the context of hospitalization or hospital admission, because they are more likely to be the reality in terms of thrombosis than patients coming from OPD to us. So there's a clinical fact that VT is an area of concern due to its incidence, and if we think that we don't have enough of it, there is enough data in India to suggest that we are no different from the West. And VT is probably the most preventable cause of in-hospital death, something that we cannot afford to let happen because it has tremendous implications medically and medico-legally. The clinical challenges that we are facing in our country is that it is being underestimated, and probably is because of either lack of awareness or because of inadequate Indian data. But over the years, this is an older data. Over the years, we know now there's much more data coming from India. So in order for you to diagnose or for us to diagnose VTE, what can be the symptoms? So if your patient has one limb or an upper limb or one lower limb or maybe two of them, where there is a swelling, there is a color change, there is pain, there is a cramp-like sensation occurring, most likely we are dealing with a deep vein thrombosis. If, on the other hand, the patient complains of sudden onset breathlessness, chest pain, a feeling of choking sensation, many times it is thought to be a cardiac event. But for all you know, it might be a clot from the leg which has disappeared into the lungs. This is called pulmonary embolism. If the patient has a severe headache, which is not subsiding with normal line of medications, then this could be a thrombosis in one of the cerebral sinuses. And if he's getting intractable abdominal pain, which is not settling down with routine medication, we might be facing splanchnic thrombosis. So the symptomatology of deep vein thrombosis will vary depending upon which is the site which is involved, whether it's limb veins or the unusual sites in the deeper parts of the body. Unfortunately for us, many times in the past, our ability to pick up thrombosis, especially pulmonary embolism, was on an autopsy. And in an autopsy which was conducted in PGI Chandigarh, the data was that many pulmonary emboli were missed for hospital admissions, and the most damning part was that many of them were young patients. So we were losing young patients to a highly preventable disease, and that's something which we cannot let happen. And hence, patients who are admitted in the hospital for various reasons, it might be medical or surgical or gynecological obstetrics, they have to be looked at from the point of view of they being a possible candidate for a deep vein thrombosis or venous thromboembolism. Now, all specialties will have to face the prospect of their patient getting a hospital-acquired VTE. The major shares are taken by malignancy, surgically post-operative state, and medically for various medical situations, especially in the ICU, or when there are complex medical issues needing immobilization. As hematologists and hemato-oncologists, we do also have few conditions which are prone towards thrombosis, especially certain types of leukemias, lymphomas, and myelomas. About 75% of the patients admitted to medicine ward and the ICU have the highest risk of DVT and PE. So these are your candidates which you have to be very careful about. And as far as surgery is concerned, when the patient he or she walks in for surgery, the surgery occurs. It may be a simple or complex surgery, but if it involves large amount of anesthesia time, immobilization in hospital, inability to be mobilized adequately and on time post-operatively, or if there is a tumor inside or there is any other lesion inside that is not being completely removed, then it can predispose to thrombosis even post-operatively. And this phenomenon can last for even up to 6 weeks to about maybe even up to 3 months. But commonly, we see thrombosis occurring even up to 6 weeks post-op. So certain candidates who are surgical candidates also need to be looked at from the point of view of DVT post-operatively. And for those of us who think that knee surgeries, knee arthroplasties are not so significant, patients are mobilized immediately the next day, they also have a high incidence. You can see in the first you can see over here in the red line that these are patients who had total knee arthroplasty and they have got a high incidence because probably they were not given adequate prophylaxis, while the hip arthroplasties were perceived to be a higher risk and are more likely to receive thromboprophylaxis. Therefore, we are seeing an inordinate increase in TKA versus THA. But remember, both are high risk for thrombosis, and therefore we have to be very clear that we want to prevent thrombosis occurring in such surgeries also. And if we did not give thromboprophylaxis to such patients, what we saw that whether it's hip arthroplasty, knee arthroplasty, or hip fracture surgery, the incidence of DVT is quite high. And unfortunately, they are more often proximal than distal. That means their chance of moving from above the knee into the lungs is high. Fortunately, the pulmonary embolisms are not so common, but hip fracture tends to have pulmonary embolism because the surgeries are longer and more exploratory in nature. And that's why the risk of going to the lungs is much higher. And if we gave them something to prevent a clot, that is thromboprophylaxis, we realized that the chance of DVT, either proximal or symptomatic, significantly decreased by almost half in these patients. Although the risk of bleeding is always there, minor risk of bleeding or minor bleeding is not so significant. Major bleeding could depend upon what is the clinical status of the patient, but that's something which we keep a watch on. And in terms of what to use in thromboprophylaxis, low molecular weight heparin and unfractionated heparin are the commonest agents used while the patient is in the hospital. And between the two, LMWH is more preferred. Either have reduced the risk of DVT, but LMWH being a one-off thromboprophylaxis, one-day prophylaxis, is far easier for the patient to take as opposed to unfractionation, which has to be twice in a day. Therefore, significantly, the incidence of thrombosis reduced with thromboprophylaxis. Now, for the medical people in the audience, patients who get admitted for medical reasons such as septic shock, severe sepsis, or surgical patients who get immobilized and then get an infection, they also have a significantly high, 1/3 of patients can develop a DVT, PE in these patients, and therefore they also have to be looked at to prevent venous thromboembolism in them. Cancer number of patients in our country are high, and you'll notice over here that most malignancies which can cause thrombosis are the ones which are in the abdomen and more often than not in the pelvis. And more often than not, they have been adenocarcinomas than squamous cell carcinomas. And if they are metastatic, then even simpler malignancies like breast cancer, if they are metastatic, can also cause thrombosis. And therefore, the site of thrombus and the type of thrombus will also tell us whether there's a risk of VTE. What did we realize out of this data? That in the ENDORS study, which is a sub-study where Indian patients were included in this study, the situation was that there was a major underutilization of thromboprophylaxis. Hardly 17% got thromboprophylaxis in India, where globally it was 50%. And our need was similar to the West. It's not that our need was lesser. Fortunately, over the years, we've realized after a discussion with various healthcare professionals that they do not know how to risk stratify patients. So now that we've got a risk stratification process on, we are able to decide who is a better candidate who needs a thromboprophylaxis. So our risk stratification is better. And instead of going from individual to universal to just giving all patients who are admitted in the hospital, or all cohorts of patients who have cardiac failure, all who are, let's say, lung failure, just blindly giving everyone is become now more individualized thanks to this risk stratification system. So awareness is better today, and with the risk stratification, we are going to give the right patient the right therapy so that our risk of clotting is less, our risk of bleeding is also less. Therefore, the right candidate gets the therapy. I'm happy to tell you, and I would urge the audience to look at this paper which I have written along with Yatin Mehta. This was in Medicine in January this year. And here, the risk assessment models which were validated in India have been enumerated. Feel free to read this paper. There's a lot of data on risk stratification over here, which I think in India is very important for us to start thinking about thromboprophylaxis so that we don't face with the dire consequences of a thrombosis. Now, once we know that thrombosis occurs in India as it does everywhere else, once we know that there are methods to prevent the thrombosis, once we know that we are able to risk stratify so that we can use the right thromboprophylaxis for the right patient, we need to know now how to prevent or what to use as thromboprophylaxis. So I'm happy to tell you that first row contains injectables, low molecular weight heparin or unfractionated heparin, or the pentasaccharide, which is a synthetic anti-10A molecule, and we have fondaparinux available with us. The second row contains the oral anticoagulants, the conventional warfarin or acetron, asaquimulone, and the newer direct oral anticoagulants. They were also called as the novel oral anticoagulants or newer oral anticoagulants, or the non-vitamin K oral anticoagulants, such as apixaban, dabigatran, rivaroxaban. We don't have betrixaban in our country. We don't yet have edexaban in our country, and there are more of these coming out. There is also, in addition to the injectable and the oral direct oral anticoagulant, we also have the mechanical ones. Unfortunately, out of fear by certain physicians and surgeons, they are being used more because they are less risk of bleeding, but the chance of preventing a clot is not as robust as the first two rows. And therefore, I urge people to use pharmaceutical thromboprophylaxis rather than the mechanical thromboprophylaxis. In mechanical, we do have intermittent pneumatic compression or anti-embolism stockings. We now also have new oral and other slow release anticoagulants which are going to come out into the market, and it's just amazing the kind of research that is going on in this area. Now, what would you want from an ideal anticoagulant? It needs a good efficacy to safety index. It needs to be oral. It should be such that if there is bleeding, we should have an antidote to reverse the. If you look at warfarin, it fits these, there's no doubt about it. And if you look at the newer oral anticoagulants, the direct oral anticoagulants, then they also fit the bill. So let's see what's the difference between the two. Why are we moving away from warfarin to the DOACs? Rapid onset of action is with the DOACs. Warfarin takes about 3 to 4 days for its onset of action. There's no need for laboratory testing with DOACs. Warfarin, you need to maintain INR between 2 and 3, at least at a time to therapeutic range which should be exceeding 55 to 60%. Then only will you get the benefit. And this is really difficult to do in real world. The kind of interaction warfarin has with several other drugs which the patient may be taking along with is hard to keep up, while DOACs have lesser interaction. The DOACs, if you look at the dabigatran, the original dabigatran, they do have a reversal agent by the name of idarosuzumab, which reverses the effect of the drug within 1 hour. Warfarin also has reversal agent that reverses in the form of a vitamin K or prothrombin complex concentrate or FFP if either is not available. Um, if you look at the dietary restrictions, then the dietary restrictions are much more in warfarin, while the DOACs don't have any dietary restriction, something which improves the quality of life for the patient. The shorter half-life of the DOACs means that even if there is bleeding, the risk of the bleeding becoming major and continuing for a longer period of time much lesser than warfarin. So the limitations of the VKAs were that of what I told you before, and the incidence of intracranial bleeding was higher than the DOACs, and that's why over a period of time we started preferring DOACs over VKAs. That's warfarin acetron. However, at the end of this discussion, I'm going to tell you who should remain on warfarin or acetron and who should be shifted to DOACs. We'll come to that. Now, if you do the comparison of warfarin and NOACs in terms of its physiology, then you will see many more attractive features of the DOACs. Remember over here that warfarin is reduces the production of certain vitamin K dependent factor, that is 2, 7, 9 and 10. While these NOACs or DOACs are inhibitors of a specific factor, for example 2 in dabigatran and 10A for rivaroxaban and apixaban. So there's a difference in their mode of action. Half-life of warfarin is longer, so it is a longer onset and longer offset. So if a person bleeds, he is likely to bleed more than one would on DOACs, because DOACs, the half-life is short. So within a matter of 12 hours, the drug is out of the body if the creatinine is normal. If you look at drug interactions, warfarin has many, while there are very few in terms of the NOACs. But if your patient has a renal problem with a thrombosis, then your drug of choice is warfarin, because the NOACs are affected by the kidney excretion. So dabigatran is the most affected. 80% of it is excreted by kidney. So if the kidney is not functioning well, it is not the drug of choice. Apixaban is been found to be a little bit better and can be used even in end-stage renal disease, even if the patients are on dialysis, albeit at a lower dose. But one would prefer warfarin in such a situation, provided you can keep the patient time to therapeutic range. You remember one thing, whenever you use warfarin, you have to overlap it for 4 to 5 days till the INR becomes 2 to 3 with a low molecular weight heparin or with heparin, unfractionated heparin. This is only the case for dabigatran. Otherwise, for the other two, we don't have to give any low molecular weight heparin. So that also becomes very attractive. And I have spoken already about the antidote of idarucizumab against dabigatran, and daxonate, unfortunately, is still not available in our country. So we have reached an era of individualized therapy based on patients' characteristics and patients' likes and dislikes, which we do long counseling with them and then take a call which drug to use. But I must say, in practice, the ability to reverse the DOAC is the most influencing event in anticoagulation. Otherwise, we were scared to use the new ones. I remember when dabigatran came out in the market for the first time, everyone says, yeah, we know if warfarin bleeds, what's to be done? If the patients bleed on dabigatran, what do we do? And that was something which prevented people from using the full dose of dabigatran. The moment idarucizumab was available in the market, the use of dabigatran shot up manifold. So reversal agents are extremely important. Now, if you look at prevention, and we have got the methodology of the drugs, is there any data that they actually work? So we've got 3 in the medical field: Medinox, Prevent, and Artemis, which was for enoxaparin against placebo, dalteparin against placebo, and fondaparinux against placebo. And what did they show? That in terms of thromboprophylaxis, it significantly prevented VTE events in hospitalized medical patients, and that too by a significant number, at least 50% or more. So that they are available and that they work, provided they're used in time, is extremely good. And we had a relative risk reduction of the main event, that is thrombosis, by somewhere between 50 to 60%. And you will see that these thromboprophylactic options in different different conditions, such as acutely ill, critically ill medical patients, oncomedical patients, oncosurgical patients, pregnancy, orthopedic and non-orthopedic surgery, you will see that low molecular weight heparin unfractionated heparin are absolute winners when the patients are in the hospital. And even mechanicals such as intermittent pneumatic compression is good. It can be beneficial, but if you look at its efficacy, then it falls short in terms of a pharmaceutical process. There are certain areas where DOACs will be helpful in non-surgical, non-ortho surgical and orthopedic surgery. There is a role for using DOAC, but warfarin is not a very suitable agent for thromboprophylaxis, because by the time you get the patient to INR 2 to 3, it's quite a few days of taking the injection, and they have to go through a lot of dietary restrictions and timings of taking the drug. Consequently, in terms of thromboprophylaxis, guideline recommendations have always leaned towards low molecular weight heparin or unfractionated heparin in most of the rows that I've shown you over here. However, there is a good grade recommendation for even the DOACs in patients who need thromboprophylaxis, especially when we need to extend the thromboprophylaxis beyond the hospital, where patients are very reticent to the use of low molecular weight heparin, that is injections at home, and they would prefer to use tablets. And DOACs have been supported in such a situation. So we are fortunate that we've got a good bundle that we can use for our patients who are undergoing surgery or medical issue where they are perceived to have a thrombosis, not only in the hospital, but perceived to continue to have that risk of thrombosis at home. We can switch to oral tablets. Many times our patients ask us this question, that how come I've got VT? I mean, how do you know I have got thrombosis? Where's the proof? And why me? Why not the guys before me who had come? So whenever there is a thrombosis, we find out, was this a provoked thrombosis or was it unprovoked? Very important. If it's a provoked thrombosis, then usually the provoking agent, if it's temporary and can be removed, then you need only short-term anticoagulation. You will need to give anticoagulation, but short-term. The moment it is unprovoked, especially if it's a male, especially if it's young, then the chance of this being a reason to keep clotting in the future makes them candidates for extended thrombosis. So in my mind, this is the first and most important thing. What is it, provoked or unprovoked? What's the age? And is there a provoking factor which will continue to provoke in the future? So do we have proof? D-dimer is a test which has been abused, but if you do a D-dimer for a suspicion of thrombosis, and if it comes negative, then that rules out a thrombosis, which means D-dimer has a negative predictive value. All thrombosis will have high D-dimers, and they are not helpful to say what is the type or level of thrombosis. You cannot differentiate from one thrombus to another. But if you suspect clinically a thrombus in the leg or anywhere else, and a D-dimer comes negative, then the chance of this being a DVT anywhere is very less. So negative predictive value is important. If it's a limb, we can do venous Doppler to prove the thrombosis. If it's in the lungs, we can do a CT pulmonary angiogram if the creatinine is normal, or we can do ventilation perfusion studies, which are not as accurate, but which might tell you a little bit of details about the patient's chance of having a thrombus. And if it's a brain or abdomen thrombosis, then we can use either ultrasound of the portal vein or the splanchnic vessel, or a CT of the brain, MRI of the brain, or a CT MRI of the abdomen along with a venogram to be able to pick up not only the site of thrombus, but the extent of thrombosis and its ability to cause extension, for example, from the portal vein into the splanchnic, further into the splanchnic circulation, or the other way around. So how do I investigate, and do I investigate? So provoked thrombosis, I do not investigate the patients. I investigate only from the point of view of APLA, because if the antiphospholipid antibody is positive, I prefer not to use the DOACs, although they are very attractive to use. I then prefer low molecular weight heparin followed by warfarin. If on the other hand, the patient is an unprovoked, then I also do again the APLA and I see which drug to use in these patients. So I look for, I divided my test into 4 categories. One is the gain function. I look for JAK2 mutation and factor V Leiden and the APLA. These are gain proteins which cause thrombosis. And this is of extreme importance when I speak about unusual site thrombosis. MTHFR mutation has now been removed from this group, and it's not considered to be so significant unless it is homozygous and it is associated with another gain mutation. On the other hand, you can have loss of function. For example, there could be deficiency of protein C, protein S, or antithrombin. Or it could be PNH, where there is loss of the PIG-A gene expression, and that's why patients can develop thrombosis. Or it can be underlying malignancies, such as solid tumors, acute leukemias, or metastatic diseases, or myeloproliferative neoplasm, which can give rise to thrombosis. Or the fourth group is miscellaneous, such as oral contraceptive pills, especially in factor V laden mutated patients, sickle cell, which is prone to thrombosis, dehydration, which especially occurs in some communities when they are fasting. Polycythemia can cause thrombosis, especially as cerebral arterial strokes rather than venous strokes. Obesity, because it is associated with inflammation and sometimes immobility, lack of exercise, and a metabolic state. Immobilization, especially post-operatively, when there's stasis of venous circulation, especially in the lower limb, or long air travel in the economy class, where the movements are restricted and therefore our ability to keep the circulation going is poorer. So these are the categories that I like to keep in my mind, so that my chances of missing most of the important tests is a little less. But I don't do all the tests. Mainly I look at APLA, and in certain situations I do additional tests. Now beyond these, I'm sure there are many other reasons for getting thrombosis. They may not be known to us, but as science advances, with these four categories, we are able to pick up thrombosis in about 45% of patients. That means still in about 50% of our patients, we don't know why there's a clot. But I have a theory, as is believed elsewhere, that fibrinolytic pathway issues could also be contributing, but we don't have robust tests for the same. Once there is a thrombus, and I know it's not APLA, I want to know what kind of treatment to start. So I'm very clear that if there is a fresh onset acute thrombosis, there is a minimum treatment of an anticoagulant for 3 months, extendable up to 6 months depending upon the clinical situation. I look at provoked versus unprovoked. If it's provoked, it should be 3 months. If it's unprovoked, it will go beyond 3 to 6 months. It will go on long term. However, if it's a provoked thrombus, but the provoking factor continues to remain, then I'll go beyond 3 months. I'll extend it likewise. If it's a thrombosis, I also look at what was the clinical status of the patient. Was it a provoked thrombosis, but the patient had a pulmonary embolism, had to be on a ventilator, had to be thrombolized, had severe hypotension? I am likely to give that patient longer anticoagulation than a shorter anticoagulation, even if it was a provoked thrombosis. I can use IV heparin, I can use low molecular heparin, I can use the DOACs in this situation. That totally depends upon what the clinical situation, and we saw that in the table which I showed earlier, how to determine which patient should use which therapy. More often than not, patients want something oral. So as they're going home, I do shift to oral anticoagulants. But while they're in hospital, I prefer to use low molecular weight heparin. And the data that I have been associated is the longest for enoxaparin. I use plenty of enoxaparin at 1 milligram per kilogram twice a day. DOACs, if you're going to use if you're going to use dabigatran, it's 150 milligram twice a day, but it needs enoxaparin at 1 milligram per kilogram for 5 days before you continue along with the dabigatran, and then you just continue dabigatran alone. However, if you're using rivaroxaban or apixaban, in that case, you can use it directly without the low molecular weight heparin loading. Rivaroxaban is given at 15 milligram twice a day for a period of 3 weeks as a loading dose, and then it is 20 milligram once a day for as long as we have discussed, 3 months, 6 months or longer. If it's apixaban, it's 10 milligram twice a day for a period of 1 week, and then it will be 5 milligram twice a day for as long as it takes. Sometimes we have to extend. Like I said, the clinical situation may have been difficult to begin with, so we need to extend. So sometimes we extend even up to 12 months. So that's a very situational decision which each physician will have to take. You can take help of your local hematologist and then take a decision together whether extension is needed. Provided there's been no bleeding events, then it's safe to continue to use the drug under supervision and monitoring. So in this situation of extension, low molecular heparin and DOACs are again a good option. Again, LMWH being injectable is not so much favored by patient, and hence DOACs is the most favored one. The idea of extending therapy is to prevent recurrence. That's the whole idea. because recurrent thrombosis will set us back significantly and give rise to more morbidity and sometimes mortality if the recurrence involves odd sites such as the brain or splanchnic circulation, or worse, it can be fatal with a pulmonary embolism. So in such a situation, we have to check the compliance of the patient. That did the recurrence occur because of compliance issues, non-compliance? Was the dose adequate, or do we need to increase the dose of this patient? On the other hand, sometimes when to prevent recurrence, we don't want bleeding. So as time goes along, some of my patients, especially after 6 months or 12 months, I've actually reduced the dose of the DOACs in order to prevent thrombosis, because now it becomes like thromboprophylaxis rather than therapy, keeping in mind that I want to reduce the risk of bleeding as time goes along. The other side of the of the anticoagulation is bleeding. I also don't want bleeding. So I have to keep a close watch. I have a reversal agent for dabigatran. I don't have for rivaroxaban or apixaban. I have for warfarin in the form of PCC or vitamin K or fresh frozen plasma that can be given to these patients. But since the world is moving away from warfarin to DOAC, we are hoping that the reversal agents for apixaban and rivaroxaban are also available. And there's going to be one which will be universal for all oral anticoagulants, which will also come into the market. Fortunately for us, the risk of bleeding on DOACs is very low. And that's why the need of such reversal agents is also going to be very low. And hence it is very attractive to use DOACs on extension basis, especially because it's oral. But there'll be certain special situations like kidney dysfunction, low platelets, antiphospholipid antibody syndrome, malignancies of the intestine, and unusual site thrombosis, where you will have to take into consideration patient's characteristics before adding an anticoagulation. Now, once you started and you probably also extended for valid reasons, the question comes durability, when to stop. It's a very difficult question. Unprovoked, most of authors will say continue as long as possible unless there are bleeding events, and then counsel the patient. If it's provoked, 3 months is the minimum time. It might be extended to 6 months, but generally we don't go beyond 3 months. So the duration for provoked is rather fixed. Unprovoked, really, we don't know. It's a clinical discussion. But if there is a constant provoking factor, or there is ongoing cancer, or there is ongoing cancer chemotherapy, then they become all constant provoking factors, and you must continue the anticoagulation in such patients. A common question is asked is, can we put an IVC filter? My answer is no. It's probably being abused. IVC filters are only applied for those people who cannot be anticoagulated, or who have got an ongoing bleeding risk, or those who have got a perceived high risk of bleeding on a therapeutic anticoagulation. Or there is a clot which has taken place, it's fresh, it's proximal, and there is a need for pelvic surgery or some surgery where during surgery the risk of thrombosis is, or the risk of pulmonary embolism during the surgery is high, and that's why IVC filter has to be put. And one last indication probably is when vascular surgeons are going to do something called as thrombosuction, they would prefer to put a temporary filter so that the clot, while suctioning out, does not go into the pulmonary circulation. Thrombosuction has been used by vascular surgeons as a means to reduce the clot burden, especially in the lower limbs where there is a phlegmasia alba, where the leg is really swollen, tight, compartment syndrome, change in the color of the leg. They have had benefits out of this in terms of short-term outcomes. However, long-term outcomes, the incidence of the thromboprophylaxis, the inflammatory changes in the leg veins is no different at the end of thrombosuction versus anticoagulation. It's called post-thrombophlebitic syndrome, PTPS. Now, we come to treatment phases. It is acute phase, recurrence, prevention of recurrence, and extended use that we have discussed. Just remember, when you're using warfarin or acetrom, you have to give first 5 days with some form of heparin. This is to prevent the actual increase of thrombotic risk when the patients are on warfarin, because in the first few days when you give warfarin, protein C, protein S, which is also vitamin K dependent, will go low and predispose to a thrombosis, which is negated by the ongoing heparin therapy that is there. Now coming to the last part of the discussion, that is on unusual site thrombosis. The splanchnic circulation is such that we've got the superior mesenteric vein which picks up from the colon, all the venous outflow. The inferior mesenteric vein picks up from the left side of the colon. Then it goes upwards. It meets the gastric vein, goes on to form the main, the hepatic portal vein, which goes inside. It has got three branches: the middle, left and right hepatic veins. It is also joined by the left gastric vein, the esophageal veins, the pancreatic or duodenal veins. So there are multiple veins which join. And this whole plexus opens out into the inferior vena cava at the end. So the thrombosis can occur either in the inferior mesenteric vein, superior mesenteric vein, the main portal vein, the splenic vein, the different portal veins, and the hepatic veins. So thrombosis can occur at multiple sites indeed. And the hepatic vein, the hepatic vein, the splenic vein, the mesenteric veins, all these together are considered to be as the splanchnic circulation, the splanchnic veins, and thrombosis in them can be detrimental to the patient's health. They can come as asymptomatic, you pick it up only incidentally on a scan. They can be because of abdominal pain, ascites, or they can be because of gastrointestinal bleeding. So manifestations can be different. Diagnosis is by a CT or MR venogram of the abdomen. Here I want to tell you that the tests are very important. More often than not, about 40 to 50% of the time, you may pick up a myeloproliferative neoplasm or PNH, paroxysmal nocturnal hemoglobinuria, or an underlying malignancy or antiphospholipid antibody in about 20% of patients. So investigation should be done based on where the thrombosis occurred. So this is an area, unusual thrombosis, that you have to be more aggressive, especially in the younger patients. Treatment remains the same, principles are the same, low molecular heparin followed by most of the time DOAC, unless it's APLA where we go to warfarin. Why should we treat these splanchnic vein thrombosis? Because once you treat them, the amount of venous recanalization, the reduction of thrombus progression, the chance of recurrence of thrombosis, the risk of bleeding, and the overall longevity of the patient all improve if you give treatment for this splanchnic circulation. So in all the primary events, thrombosis, recurrence, bleeding, health-related quality of life, everything, it's better to use anticoagulation than not anticoagulate such patients. Likewise, in cerebral circulation, we've got these sagittal sinuses, plenty of them, and several other veins which constitute the cortical venous sinus thrombosis, cortical venous sinus plexus. So it depends upon where the event has taken place. You can get different types of symptomatology and manifestations, as I'm showing you here, based on which is the vein or plexus that is going to be affected. So affected territory, the rapidity of the occlusion, the degree of collateralization that can take place, and how much is the damage to the brain tissue, underlying brain tissue, determines what kind of symptomatology we'll have. And some of these actually may also have hemorrhage in the thrombosis, and that is not a contraindication to treatment. So unlike in the arterial thrombi, where if there is bleeding, we are worried of using anticoagulation, in venous, we do not allow it to be a contraindication. So at the end of the day, thrombosis, wherever it occurs, it increases the intracranial pressure, it causes cytotoxic and vasogenic edema, disruption of the blood-brain barrier, parenchymal hemorrhage, and hemorrhagic infarct. How do I treat it, the cortical sinus event? Similar as any other thrombosis. And fortunately for us, there is data emerging for DOACs in this situation. So DOACs, they have the advantage, and there is now a growing evidence that in splanchnic circulation and cortical sinuses, sinus thrombosis, we can use DOACs. Unfortunately, the number of patients accrued onto the trial are lesser, and that's why it's taking time to make the guidelines make this change. But studies such as SECRET, RESPECT, all are showing that we can use the DOACs in unusual sites also. So if you look at splanchnic vein thrombosis, if patient has, yes, warfarin would be the drug of choice, but in patients with Child-Pugh B, liver disease, rivaroxaban should be avoided, should not be used. And if it's C, none of the DOACs should be used. So amongst them also, you have to be careful how you characterize your patient and how you use it. In cortical sinus thrombosis, again, warfarin would be the drug of choice, and there's very vibrant data for dabigatran. But for if you can't use either of them, then rivaroxaban and apexaban have also been studied in these patients. What about in the APS? I kept saying APLA syndrome, antiphospholipid antibody syndrome. We are worried. We have to test, because if you use DOACs in the current dose, there is a risk of a recurrence or increase in the thrombosis, and that's why VKA, that is warfarin and acetrom, are the drugs of choice in these patients. We should use that. If you're going to use DOACs in these patients, then our risk of recurrence is higher, even if you are giving a therapeutic dose. So DOAC should be given only for patients who, despite you counseling them again and again that warfarin should be therapeutic, then only you can switch to a DOAC. And I think probably at a higher dose than what is therapeutic. We don't have data for that, but there's an ongoing study for that. So a huge amount of discussion takes place with the patient. They have to understand that they have to stick to warfarin, do the tests regularly, so that they don't have to be exposed to DOAC, which might be inferior to them. So I had promised you, I'll tell you which patients should remain on warfarin and which should be switched over to the DOACs. So let's see the DOACs. If your patient has had a history of intracranial bleeding, then the DOACs are a better drug to use. If the patients are at a high risk of stroke, then keeping the warfarin INR therapeutic is tough, and therefore DOACs might be better. If your patient is unable to take warfarin on time, they have logistic problems that interfere with laboratory monitoring, or who don't want to do a test because they are alone, they don't want anyone to enter their house, DOACs is better. For patients who are unable to keep a time to therapeutic range above 55 or 60%, should be switched to the DOACs. Patients who have got other drugs which have been added and warfarin is causing them to have a drug interaction should be switched to DOAC. And there are some who say, I don't want to take warfarin, I want DOACs because they are going to be much more better for me in terms of quality of life. As long as they fulfill the criteria, you should give them the chance of going on to DOACs. Likewise, which patients are definitely to remain on VKS, that is warfarin. So patients who are stable INR with a low bleeding risk, don't change them. They're doing well on warfarin, leave them alone. Let the sleeping dog lie. Don't disturb it. For patients who have got recurrent dyspepsia, like nausea, vomiting, who have GI complaints, who got piles or who got an ulcer in the past, please keep them on VKA. It's safer than going to DOACs. Patients who had a history of myocardial infarction, there was some data in between that dabigatran might predispose. This has now been refuted. The DOACs can still be used. Patients who prefer to continue with the warfarin after receiving complete information about the pros and cons of the DOAC should continue to take VKs. You must not influence that decision. And those who have severe renal failure, warfarin is the drug of choice unless we switch to apixaban. And those who have mechanical heart valve, there's no doubt DOACs have failed in them, and warfarin is the best drug of choice. In cancer, this is another special situation where, because of the tumor cell, there is secretion large amount of products which make the patient prothrombotic. And you'll notice here, from the diagnosis to hospitalization, when the patient becomes sick with inflammation being one of the reasons, then going to chemotherapy, the risk of thrombosis is high. Now, if you compare the risk of thrombosis in the general population, which is here, to the risk of thrombosis in a VTE or VTE in a cancer patient, it is 4 times higher. That the fact that the patient has got a cancer increases the risk 4 times already. And then you're going to hospitalize, surgery or chemotherapy, the inflammation increases, the risk goes even higher. And as the patient's chemotherapy takes place and the patient goes into remission, the risk starts coming down, but never to the normal. Only for it to become worse again if the patient was to relapse or develop metastasis, and this will continue till the end of life, where the risk of thrombosis will constantly be high. So cancer is another special situation where thrombosis risk is constantly high, and it's a moving target as the patient undergoes diagnosis, admission, treatment or surgery. And the worst part is that in these cancer patients, it's not only related to the tumor or to the site, even the treatment can cause thrombosis. And then the patient has their own patient-related comorbid situations that can add to it. And there are certain biochemical and CBC markers that can predispose. So it's a mayhem. It's kind of a very unholy nexus between various variables that can cause thrombosis in cancer patients. And if they were to undergo surgery, the chance of them having thrombosis is higher. So those patients who undergone surgery, the chance of getting a VTE is going to be higher in the first 30 days post-operation, and that's why I urge you to give them thromboprophylaxis post-operatively. There's a nice consensus in thrombosis research which says that DOACs were more effective than low molecular heparin to prevent recurrent VTE, but were associated with a significantly increased risk of major bleeding. So if your patient has lesser risk of bleeding, DOACs is the way to go. If there's a high risk of bleeding, especially in the GI tract or genitourinary tract, low molecular heparin is even better. And the guideline statement has mentioned that individualized treatment regimens after a shared decision, specific DOACs for cancer patients with acute diagnosis of VT who have a low bleeding risk and no drug-drug interactions with systemic therapy, go for DOACs. Otherwise, go for low molecular weight heparin. Now, if you have a patient who has a cancer-associated thrombosis, ask the following questions. Okay, is there any anticoagulation contraindication? If there is, look for any bleeding factors. There's no bleeding risk in this patient. There is no luminal cancer, no urothelial cancer, genitourinary, and there is no drug-drug interaction. Your patient is classical for starting an anti-10A or anti-2A inhibitor, but the amount of data on dabigatran is less for cancer. So either it's rivaroxaban, apixaban, and if edoxaban becomes available, then that. Reassess your patient as time goes along. But continue therapy till the cancer remains active or the patient remains on anti-cancer treatment. However, if there is no contraindication to anticoagulation, but there is a bleeding risk, there is a GIT or a GUT malignancy, where the risk of bleeding is high, and there are drugs which can interfere with the DOACs, then it is better to use an injectable such as low molecular weight heparin in these patients. Now, the data of enoxaparin and dalteparin is robust, and they can be used in these patients. So my take-home messages from this discussion is, we must keep in mind VTE in admitted patients especially, based on the symptoms that I told you about. If we have a high awareness for these symptoms, especially in the hospitalized patients, especially in certain groups, then we can pick this up earlier. Now we want to prevent this, and that's why risk stratification is important. We should be able to prevent the patient from getting a thrombosis rather than looking for symptoms of patients who have thrombus. Cancer and unusual sites need different investigations, different line of treatment, and a different way that we are going to manage these patients even on a long-term basis. While the patient is in hospital, low molecular weight heparin, either enoxaparin or dalteparin, is a clear winner because its interactions are least, the risk of bleeding is less, and therefore the patient can continue to take it. But once they go home, maybe DOACs can take over because they are non-inferior to warfarin in terms of treatment and prevention of recurrent VT, significantly lower risk of major bleeding. There's no titration needed. There is no worry about doing tests again and again. There is no issues with food and preventing certain dietary and having certain dietary restrictions. Thrombolysis as a modality is more likely for pulmonary embolism only for those patients who've got a hemodynamically compromised pulmonary embolism. That means they've got tachycardia, blood pressure is dropping, and there's a PESA score which tells us that yes, the chance of this patient going into hypotension is high, and therefore we should thrombolyze such patients. IVC filter, I told you, it is temporary. It should be a temporary filter, and only for certain situations it should not be abused. And this is to prevent pulmonary embolism. Surgical thrombectomy, very few cases to reduce the thrombus load when it is massive. And mechanical method is to be used only if the patient is not anticoagulable. And once it is started, try to find out how to get to the pharmaceutical anticoagulation and use both together. That will be helpful. So I thank you very much for your attention, and I'm happy to take any questions if there are.
Great job. I mean, I'm sorry I'm not able to come there, but they were quite insistent, and Sandeep at short notice has been able to, with Mr. Pramod, has been able to actually do this recording. So I'm very thankful to them because I wanted to be part of this meeting. I know Sandeep from the time when he was a student, and he used to sit with me in Nair Hospital and would answer all my questions. So, I'm so proud of what he's done just now. And more importantly, Sangli is my birthplace. So I was very looking very forward to being in the city and going around to areas of my birthplace interest. And I'm just disappointed I'm not there. But I'm hoping that the Usha Hematology Center and the NERA laboratory are going to, as was beautifully mentioned earlier, will add more feathers to the cap, which already Sangli and Mira as twin cities have, but it's going to augment hematology services over there. And if it's with the help of mentors like Dr. Vikram Matthews and Dr. Sukesh Nair, then it's going to be even better. So my best wishes to them. I hope they do very well. And my very warm regards and respects to both the dignitaries who have come from Vellore. And I hope to meet them one day again. Best wishes. Thank you.
Thank you very much, Dr. Abhay Bhave, for such a lucid presentation and knowledgeable talk. In spite of being unwell, you have managed to deliver such a speech using digital platform. It means a lot for us. And there will be, I'm sure, very many more occasions for you to visit Sangli. Thank you once again, sir.
Thank you. Thank you very much.